Giorgio. May I?
Yeah. So I will discuss a clinical case, and we will see how we can use IntelliVent ASV. These are my conflict of interest. So welcome in my hospital. This is Toulon Hospital. We will receive a young lady that is transferred from a nearby hospital. She's 28 years old, no past medical history. She was on holidays in Southeast Asia, and she came back two weeks ago. And 4 days ago, she complained of abdominal pain. So she was prescribed ciprofloxacin. And yesterday, she was admitted in this private hospital. They performed CT scan, abdominal CT scan. They performed coloscopy, and it was abnormal but not specific. So they decided to do for laparotomy. On the induction of anesthesia, there is a suspicion of inhalation. On the laparotomy, they found a peritonitis without intestinal perforation. So she was operated, extubated after surgery, and monitored in a sort of step-down unit. This morning, this lady complained of hypoxemic respiratory failure with hypotension, so she was re-intubated and transferred to our ICU. So she just arrived in the room, and rapidly the nurse will transfer the ventilator from transport ventilator to the ICU ventilator. The nurse will position the sensor, SpO2 sensor, and the end-tidal CO2 sensor, and rapidly they will measure the patient, and actually the height is 170 centimeters, so which is 61 kilograms of predicted body weight. This is a chest X-ray on admission. So what we will do now, we will start to activate IntelliVent. So to activate IntelliVent, is it possible to reduce the size of this screen because we don't see the upper part? So on the top of the screen of the ventilator, we have to activate the 3 main controllers: minute volume controller, PEEP controller, and FiO2 controller. Then we have to select a patient condition. By selecting a patient condition, the ventilator will propose different default target ranges for both FiO2, end-tidal CO2, and SpO2. So we may select RDS, chronic hypercapnia, brain injury. If we don't select any, it means normal lung. So in this case, I think we should select RDS. Then we have the quick win function. For the moment, the patient is sedated, so we won't activate quick win. Then we have automatic recruitment maneuver. At this point of time, I would be very careful to use automatic recruitment maneuver because we are not sure about the hemodynamic condition. And the limits of PEEP between 5 and 15. Again, at this point of time, I would be very cautious and limit the maximum PEEP at 12 just because I don't know about the hemodynamic condition. And so with these settings, the end-tidal CO2 target range by default is 37 to 44 millimeters of mercury, keeping in mind that there may be a gradient between end-tidal and PaCO2, and the SpO2 target range are 92 to 96%. So now, currently, can we close this panel? Yeah, we see that the patient is totally passive. She's sedated. The minute volume controller is adjusted according to the end-tidal CO2. So currently, the end-tidal CO2 is within the target range, so minute volume is not changing. And for this given minute volume, the ventilator measures the respiratory mechanics, namely the expiratory time constant. It's currently very short. Why? Because this patient have a very low compliance, 34. So it will deliver a combination of tidal volume and respiratory rate with a low tidal volume, 5.5 meter per kilogram of predicted body weight, and a high respiratory rate. If we look at the oxygenation controller look at the SpO2 of the patient, compare it to the target, and actually you see that the SpO2 is higher than the target, so FiO2 is decreasing. So half an hour later, we may have a blood gas analysis that show that with 10 of PEEP and 95% of FiO2, PaO2 is very low with a pH ratio below 100, so it means it's a severe RDS case. In the same time, we see that there is a severe acidosis, which is mixed, both metabolic and also due to hypercapnia. So after this blood gas, we may change a little bit the settings and change a little bit the target PaCO2. If we shift the end-tidal CO2 to lower value by 5, for example, we would decrease the PaCO2 by 5 and increase the pH at around 725, which is, I think, the minimum. By doing this, now the end-tidal CO2 is higher than the target, so the minute volume will increase, and this will be transferred in an increase of tidal volume or respiratory rate. Currently, the respiratory rate increase. So now we may assess a little bit the hemodynamics. So in my unit, we would use a cardiac echo. Actually, the left ventricle function is normal. There is no right heart failure. And we found that the patient is a little bit hypovolemic, so we give a little bit of fluids to stabilize the condition. And now that the hemodynamic condition is more stabilized, we may increase a little bit the limit of PEEP. Okay, unfortunately we don't see it, it's here. So we increase the maximum PEEP to 20 centimeters of water, for example. At this point of time, I think we have to decide which recruitment strategy we should use. It's a severe RDS. And to do this, we may use the bedside assessment of recruitability using a low-flow PV curve, looking at the low inflection point, linear compliance, and hysteresis. So we can do it on the screen. We go to the PV tool, and we will set the PV tool. Okay, starting at a PEEP of 0, going up to 40 centimeters of water, going back to 0. Then, sorry, it's split it. So we have to use a very low ramp, as low as possible. It's a slow flow PV curve and no pause. If we set a pause, it's already a recruitment maneuver. So on top of the current ventilation, we will do a PV curve. So pressure will go to 0 for a few seconds, and the pressure will increase from 0 to 40 over 20 seconds, and from 40 to 0 over 20 seconds. So the full maneuver will length 40 seconds. This is displayed here. During the maneuver, we have to keep an eye on the monitor to check the mean arterial pressure. If at any time the mean arterial pressure goes down, we may stop the maneuver right away. So the maneuver is still ongoing. I'm sorry that the screen is split in two. It's not very convenient for you. Okay, and so you have the lower part of the PV curve here, the upper part here. First, what we will see using the cursor number 1 is to look if there is a low inflection point. Obviously, there is one at around 13 centimeters of water. Then we have to measure the linear compliance, which is the compliance of the recruiting part of the PV curve. And here, using the cursor number 2, we see that the linear compliance is around 100, which is very high, meaning that there is a lot of recruitment during inflation. And then we may look at the hysteresis, which is a surface between inflation and deflation. To do this, we put a cursor at 20 centimeters of water and measure the volume difference between deflation and inflation. And here we read that the volume difference is 1,300 milliliters, very high, meaning that this patient have a high potential of recruitment. So I think we should perform a recruitment maneuver to this patient. So we can use exactly the same tool to perform the recruitment maneuver. And now we will start at the actual PEEP, so 11. We will perform a recruitment maneuver at 40 centimeters of water, and very importantly, increase the PEEP after the recruitment maneuver to keep the lung recruited. So, for example, 20, and we'll decide later. We can use a faster ramp and a pause at 40, so usually we use 10 seconds. So it's a sustained inflation recruitment maneuver, 40 centimeters of water for 10 seconds. And so you see that on top of the current ventilation, now the pressure will increase from 11 to 40, maintain the pressure at 40 for 10 seconds, and then go back to the new level of PEEP, which is 20 in this case. Okay, so during this time again, we check the hemodynamic of the patient. And now you see the recruitment maneuver is finished, and we change the PEEP to the new level, which is 20. Can we measure the recruitment? Okay, what you see on this curve, I'm sorry it's not so clear here. This volume increase, you see at 40 we have a volume increase. This is an assessment of the volume that was recruited during the recruitment maneuver. So we may estimate that we were able to reopen around 500 milliliters to this patient. So now you may see that after the recruitment maneuver, the compliance of the lung increased dramatically because we reopened the collapsed lung, and the SpO2 increased, so now FiO2 is decreasing. So after this, what I would do is a decremental PEEP trial, so I will keep the PEEP manual and decrease the PEEP progressively, 20 to 18, 18 to 16, and so on, looking at the SpO2 and the compliance until we found the level of de-recruitment. So by doing this, we found, and we set the PEEP at 14 centimeters of water. Okay, so if we found that the optimal PEEP is 14, then we can go back to the settings and set the limits of PEEP between 14 as a minimum to 18, for example, as a maximum. So that we keep a minimum PEEP and we let a little bit of space for the PEEP to play in case of disconnection, suctioning associated with de-recruitment. And so we have a blood gas with this level of PEEP. You see that FiO2 decrease and the PF ratio increase, and the PaCO2 was partially corrected. This is the evolution of the ventilation variables between admission to 44 hours. So the PEEP was 10 on admission, increased to 14 after the recruitment maneuver. We kept the PEEP at 14 for 20 hours and then decreased it progressively. FiO2 was very high on admission, decreased after the recruitment maneuver, and decreased afterwards. PF ratio was very low on admission, increased after the recruitment maneuver, and kept increase afterwards. The tidal volume on predicted body weight was around 5 on admission and around 6 afterwards. The plateau pressure was always below 25, and the driving pressure, plateau pressure minus total PEEP, was around 10, 11 all along. So after 44 hours, we see a great improvement in the PF ratio that is above 200. So at this point of time, we would stop sedation and let the patient trigger. So this was the chest X-ray at 44 hours. And now what you can see is that the patient starts to open her eyes, and we will see the switch between controlled ventilation and active ventilation. It's very easy to see because when you see these triangles, it means that the breath is triggered by the patient. Okay, you can see it on the dynamic lung by the diaphragm. Okay? So as soon as the patient triggers the breath, the ventilator switch from pressure control mode to pressure support mode. And then, now the regulation of the minute volume is no more based on the end-tidal CO2, but on the patient respiratory rate. Meaning that if the patient respiratory rate is very high, the target minute volume increase in order to increase pressure support. And reversely, if the respiratory rate of the patient would be low, this would decrease the target minute volume in order to decrease pressure support. So now the patient is waking up, so at this point of time, we should activate the quick win. So we activate quick win. Quick win function is an automatic protocol implemented in the mode to help the clinician for weaning. So it uses a 3-steps approach. The first step is screening of the readiness to wean criteria and trying to reduce ventilation support. The second step is an observation phase. We want this readiness to wean criteria to be fulfilled for a certain period of time, and then it will perform an automatic weaning trial. So currently, we activate quick wean, and we see that the ventilator will screen the readiness to wean criteria, FiO2, PEEP, tidal volume, pressure support, RSB, and the spontaneous respiratory rate. So all of these thresholds can be determined by the user. For example, in my unit, we decide to start weaning if FiO2 is below 50, PEEP below 8, and respiratory rate below 35, but you can configure it as you want. So after the end of the observation phase, it will switch to an automatic weaning trial. This is displayed by this green light. So during the weaning trial, the minute volume decrease as much as possible in order to decrease pressure support. So currently, pressure support is 5. PEEP is set at 5, but you can decide any number between 0 and 5, and oxygen is still running. So currently, the patient is doing a weaning trial with 5 of PEEP and 5 of pressure support. It's a very safe weaning trial, meaning that all the parameters are still monitored during the weaning trial. If SpO2 goes down, FiO2 will increase. If FiO2 goes above 60, it will abort. Here, for this case, we set a weaning trial of 1 minute. Usually we use 30 minutes. And so at the end of the weaning trial, the ventilator will go again to the previous settings and display a message that the weaning trial was successful. So at this point of time, we should consider to extubate the patient. So this is the end of the story. The patient was extubated on day 5. She used high-flow oxygen for 1 more day, and she was fine and transferred in the surgical ward on day 6. The blood cultures confirmed that it was a Salmonella enterica phenotype typhi, so it was a typhoid fever, and the RDS was due to inhalation and sepsis. So the conclusion, IntelliVent ASV is a full closed-loop ventilation mode. Clinician has to set and to adjust the targets, end-tidal CO2 and SpO2, and the limits. As you see, it's easy to set and to monitor because it's pressure control and pressure support. It helps the clinician to apply protective ventilation and provide an automatic weaning tool. Thank you for your attention.